Yes.
It's already recording? Okay.
Yeah.
So I think we can start today's lesson. So Dr. Leontine Lazar is about to explain us which are the improvements and the latest news about DCB in peripheral artery disease. So this, Leo, is this more a case-based presentation or more science?
It's a mix of science and I put just one case we did last year in
Okay.
one of the hospitals I work, but it's basically more science than case-based.
Okay, because there have been few interesting studies published so far in the last 6 months about DCB in the periphery. And so I'm happy you are doing this presentation now because there is a lot to discuss. So please,
Yes.
let's go.
Hi, everybody. I'm happy to join you again for this presentation. I'm not sure how is the policy in everybody's country, but here in Romania, the interventional cardiologists are usually doing peripheral as well, not only lower extremities, but also upper body, meaning renal arteries and carotid stenting as well. So I'm not sure if I chose the right topic for everybody, but for me, doing peripheral procedures and using DCBs has led to an improvement in using DCBs in coronary disease. Because at first, I think everybody has a bit of questions regarding the results after DCB and whether you should leave the dissections as you have it or not. But after using it in peripheral artery disease, where the risks are not so high, even if the vessel is closed, you can re-enter, and it's not a big deal usually. You can gain more experience and more courage to use it in de novo lesions in coronary artery disease. So basically, this is why I chose this topic, and I hope it's gonna help all of us. So as we all know, peripheral artery disease is the third cause of cardiovascular morbidity after coronary disease and stroke, with a high prevalence all over the world. It leads to significant risk of amputation and other MACE such as MI, stroke, and even mortality. And we have as treatment options medical treatment, bypass surgery, or percutaneous interventions. Not every lesion that we find in peripheral artery disease, especially in lower limb artery disease, has to be stented or treated by revascularization. We only have to treat those lesions that affect the quality of life by intermittent claudications, and it depends on the location and the anatomy of the lesion. Usually in femoral popliteal lesions, drug-eluting treatment should be as the first choice treatment. According to the last year's European Society of Cardiology guidelines, while in iliac lesions, primary stenting for the common iliac artery should be the first choice. For the femoral popliteal lesions, if revascularization is indicated, endovascular therapy should be considered. When surgery is indicated, then autologous vein graft should be used. For the below the knee disease, the things are not such, don't have so much data, but in patients with severe claudication, endovascular treatment of the below the knee arteries may be considered in the same interventions.
Leo, can you come back?
Yes.
So on the right, the guidelines state in femoral lesion, drug-eluting treatment should be considered. So what type of drug-eluting treatment they are referring to?
Both drug-coated balloons and drug stents, but stents that have a high rate of deformability, if I can say that. Meaning there are two types of stents that you can put in a superficial femoral artery. That is the Viaban, which is very robust, and also
Viaban is not drug-eluting. That's a
yes,
chorus.
Yes, it's not drug-eluted, but they say that you should use a drug-coated balloon before using it, before using stents. Even bare metal stents can be
No,
used.
but this is not stated by the guidelines. The guidelines
Uh,
are not stating to use DCB plus viable because there is no single study.
They have studies on femoral superficial artery and popliteal artery. It's not, they are not so well stated in the
Yeah, but it's not
European.
a randomized study, so it's not the guidelines recommended. So the topic is they're suggesting drug-eluting treatment. But what type of drug-eluting? So DES, so drug-eluting stent or drug-coated balloon?
No, primary drug-coated balloons. Every trial has compared drug-coated balloon with normal balloons.
I
So they
know.
are they are
So there
referring.
is evidence for DCB, and there is more limited evidence also for drug-eluting stent, but the guidelines should mandate and say, this is the area for drug-coated balloon, this is the area for DES, and here the guidelines are not clear, at least from this table.
Yes, exactly. And in the text, they are also referring to some studies. And if you open those studies, in those studies, they are using they say that they use the drug eluting treatment by using a drug-coated balloon followed by a bare metal stent, for example. And they use this term for the combination of treatment
Okay.
as drug-eluting treatment. But the studies, the randomized trials, are mainly with only with DCBs for the femoral popliteal lesions.
Yeah. Okay, let's go ahead.
Okay, so DCB in peripheral artery disease are mainly the rationale and the technique of using it is similar to coronary artery disease, but there are some differences that should be noted. First of all, we cannot forget the meta-analysis from 2018. I think everybody knows about it from Katsanos, which show that paclitaxel-coated device, including stents for femoral popliteal arteries in lower limbs, is associated with a significantly increased risk of death. The meta-analysis had around 4,000 patients, and they saw a 7.2 versus 3.8 increase in mortality at 2 years, with consistent increase in 5 years. So after this meta-analysis, the FDA in 2019 recommended a restriction in use before further investigation. This further investigation, however, showed that paclitaxel-coated balloon not only don't affect and don't increase mortality, and they show this in different trials and studies published in respectable journals like New England Journal, The Lancet, CCI, and so on. But they also show that paclitaxel-coated balloon improve long-term patency even in very complex femoral popliteal lesions. And this finding led the European guidelines to say that drug-eluting treatments, how they say, but they are mainly referring to PCBs, improve long-term patency and should be considered. So how do we use it in peripheral disease? As in coronaries, lesion preparation is also crucial. There are, however, some differences. For example, when we do the pre-dilatation with standard balloons, we should always inflate them for longer periods, at least 2 or 3 minutes. There are some studies that show that best results are obtained with even 5 minutes of prolonged inflation. What is more, cutting and scoring balloons are highly indicating because they produce less barotrauma and major dissections, so they improve long-term patency. Different atherectomy techniques are also encouraged for highly calcific lesions, and almost always we see very calcific lesions in peripheral disease. There are some studies that show that using orbital atherectomy improves patency with a numerically higher but in most important studies, this didn't reach statistical significance. In another study, rotational atherectomy, for example, showed that target lesion revascularization at 6 and 12 months is reduced when this technique for predilatation is used.
Yeah. So since Leo, time is tyrant, you still have
Okay,
six
I'm
minutes.
gonna summarize it.
Yeah, but I would like you to update us on the latest studies that have been presented for the periphery.
Okay.
Okay.
So, directional atherectomy as well has been tested in recent trials like definitive trial. The IVL has also been tested, and all of these are recommended because they improve procedural success and they lead to fewer flow limiting dissections. What is more, imaging is also very important because IBUS or OCT guided procedures lead to an increased freedom from clinically target lesion revascularization and prolonged patency. So there are some papers that propose some algorithm for DCB in peripheral artery disease. One of them is written by me and my colleagues, and we propose a similar algorithm as in coronary disease, as recommended by consensus. With pre-dilatation, with semi-compliant, non-compliant cutting balloons and so on, and the plug modification techniques. Assessing preferably with imaging after that, and if we don't have any significant residual stenosis or no or flow limiting dissection, we can go further with DCB, and after 5 minutes after the delivery, we can reassess and decide whether to leave it like that or not. However, we should mention that very rarely we do around 400 procedure a year, peripheral procedures. We almost never use stents. Even if we have flow limiting, we prefer to inflate again the balloon, keep it for 3 minutes, deflate, and repeat the
Yeah.
process 2 or 3 times. And
This
usually
is
that's
an
enough.
important educational point, and I agree with you. But I have a question. So here you mandate the usage of intravascular imaging always for the peripheral intervention for SFA, if I understand well.
Yes.
Yeah. So you are using imaging in all of the cases?
No. Because
Okay.
for
In which percent?
peripheral,
Yeah. In which percentage of peripheral are you using?
we only use IBUS for peripheral. We don't have OCT reimbursement, and neither IBUS. We have to do also an IBUS investigation in the coronaries. So only in those patients who also have coronary disease, we can use intravascular imaging. So it's
Okay.
about
But so which
10,
is the
20%.
percentage of imaging usage in your PTAs?
Probably 20% max.
20%. Okay.
Yes,
So why do you write an algorithm where you mandate and recommend always to use imaging?
because these are the recommendation. The general recommendation is not based only
Oh,
on our
so
practice.
in the guidelines, they are stating that you should always use imaging for peripheral?
Not always, but is recommended.
Yeah, but it's not always, it's different. So recommend, what does it mean? So we need to speak about numbers because this is an important information. Okay, so there are limited data, showing the utility of intravascular imaging, and it's clear. We have seen with a lot of data for coronary, so why not for peripheral? Okay, there are limited data, but there are reimbursement issues, okay, which lead
Yes.
to, my center is one of the best endovascular center in the US, okay, with Medi, okay. So they are leading clinical trials publishing in the New England Journal of Medicine, okay. They are not using imaging for peripheral. They're using it in, I'm thinking 5 to 8% because of lack of solid data, lack of clear recommendation from the guidelines and lack of reimbursement. So in an
Yes.
ideal world, you can say, okay, in a perfect PTA, I would like to do this, this, and this. But then if you see the reality, you recommend using it in your algorithm, but then you use it in only 20% of the cases. So you cannot say, let's do imaging, because nobody will use it for all of the reasons that I have said. So we have to be very balanced when we give recommendation, because from what you said, it was clear that we should use imaging always, but this is not what the data and the guidelines are saying.
Yes, I agree. They say it has the possibility to improve outcomes, but it's not a clear RCT to recommend this firmly.
Yeah, so maybe also in the algorithm you should write, or whoever is writing the algorithm, okay, in some selected cases, which are these, and these, for example, it comes into my mind the instant restenosis for the SFA. So in these cases, we strongly recommend using imaging because these are the advantages. This is more real life. If you are giving a suggestion with an algorithm, you should be very close to what people is doing in their routine and everyday practice, and not just say, okay, use it because theoretically is the best thing, and then nobody would use it.
Yeah, you're right.
All right. So thank you. Let's go ahead.
So when we talk about peripheral disease, we talk about above the knee lesions and below the knee lesions. Mainly, we have two categories in every above and below the knee lesions: instant restenosis and the novel lesions. For the instant restenosis above the knee, their use of DCB for treating aortoiliac lesion is rare, and very few studies have used this approach. The most important in the recent trials is the PACUBA trial. They didn't enroll so many patients. Actually, in most of the trials, the number is around 100 and something patients. In the PACUBA trial, the use of paclitaxel-coated balloon versus the simple balloon angioplasty led to a higher primary patency rate of 40.7%. In the FAIR trial also, for the FEMPOP instant restenosis, recurrent instant restenosis after 6 months was much lower in the paclitaxel-coated balloon group. Also, the debate ISR study with only 44 patients with FEMPOP ISR showed a lower TLR rate in the DCB group. We also have some trials for de novo lesions, including pacifier trial with 85 patients, which showed that DCB angioplasty is associated with significantly lower late lumen loss and fewer restenosis. In the Levant trial, the Levant 2 trial, which is one of the biggest trials on PCBs in de novo lesions for above the knee lesions, paclitaxel-coated balloon showed a significantly higher patency, while the IMPACT SFA trial showed that DCB treatment is associated with higher 12 months patency. Regarding below the knee lesions, the data is much less because below the knee lesions are much complicated to treat, and they are treated in fewer centers. So for the novel lesions, we have the Biolux P2, which had a primary safe point as a composite of all-cause mortality, target major amputation, lesion thrombosis, and target vessel revascularization after 1 month, which was 0% in the DCB group, with 8.3% in the standard PTA group. And also we have the IMPACT DEEP trial, which is the largest one on critical limb ischemia due to below the knee lesions. We show that 12 months follow-up, the co-primary endpoints represented by TLR and the late lumen loss were similar between the two groups. which was 9.2% in the DCB and 13.1% in the PTA group, while the late lumen loss was also similar. Regarding in-stent restenosis for the below the knee lesion, the data is even scarce because it's not clear if we should ever use stents below the knee. In our practice, we used to use a lot of stents, coronary stents for the below the knee lesions when back in 2016-17, when we had the important dissections, we are always using stents. We are always using bifurcation techniques for the peroneal and anterior tibial arteries, but they always have restenosis and they don't have good patency after 1 year. So in-stent restenosis is difficult to address with DCB because stents were not so highly used in Europe and in the world in other centers back in the days. However, there are some studies that show that drug-eluting stents might improve rates of primary patency, but with doubtable results. So DCBs has emerged now as a promising tool for these ISRs. However, we don't have data regarding long-term clinical results, which we should have to be able to address this issue. So in the end, I would like to share with you a case we did.
Wait a second. So Leo, you are missing a lot of studies that came out in the last 2 years about DCBs in the periphery.
In the
So
below the knee.
many studies. No, above the knee. I'm talking about above the knee. Below the knee is different. It's I agree that it's a complex milieu. So now recommended treatment is POBA. But for above the knee, there are important studies that came out. For example, with sirolimus coated balloons. A lot of studies. So you mentioned only studies that were published 10 years ago or 12. The debate is more than 10 years ago. So there is the Sirona study. It's a randomized study between paclitaxel and sirolimus. We have 1 year data, primary endpoint. There is another study, I don't remember the name, with Solution, presented in Japan 3 months ago, with a 3-year follow-up. It's a prospective registry. It's not a randomized trial, but it's showing very important and sustained data. So, you need to work on an update of this presentation. And I want you to speak with Sarah and do this second part on last 3 to 4 years of DCB usage in the periphery within 1 month from now. It's very important to be up to date.
The Sirona, I know about him, but the other one I didn't read about it.
Yeah, you can go to clinicaltrials.gov. You can go to TCTMD, dhar.org, CRT online, all of these things. And then from there, you go to the presentation. And from there, you go to PubMed, you find the publication. If you don't want to do, you start from PubMed. Okay? You can be assisted by somebody. I think that Evan can help you in that if she's willing to do a research for you for updating this presentation.
Okay.
So you can work together, and within 30 days from now, please schedule another, very fast lesson. We can do it also after another already planned lesson about this.
Okay.
Okay, thank you.
Yes, absolutely.
Thanks a lot. Okay, you have a case that you want to present also?
Yes, I will show you very fast the case we did a few
Thanks.
months ago. So this was a subacute patient which had a critical limb ischemia with a total occlusion from the origin of the superficial femoral arteries. The patient was severely symptomatic. He had only one station in the distal femoral and proximal popliteal artery. After that, the peripheral below the knee arteries were not seen during injection, only the peroneal artery. So we tried to use an antegrade approach, but we didn't manage to pass the popliteal artery. So we used the retrograde approach in the mid peroneal artery. We managed to go up in the femoral artery.
So you use the dual approach from
Exactly.
left groin and from the pedal artery?
Exactly.
Okay.
So we did a tipping in the catheter in the femoral artery, and then used an antegrade approach to treat the vessels. We use a full DCB approach, using a DCB for the posterior tibial artery, balloon for the anterior tibial artery, and this is how the popliteal and the tibial and peroneal artery looked like after several DCBs. Further on, we had a major dissection at the ostium of the femoral artery, so we used supera stent to cover it because the patient started to have very bad pain. And we went further on with a DCB in the mid part of the femoral artery. This is the final result in the foot. And this is the final result in the femoral artery and in all the arteries that we treated. So the main point for which I wanted to show you this case is the dissections that we had, and for which we used our approach of inflating balloons over and over again. However, in this case, we had to put a stent in the proximal femoral artery because every time after deflating the balloon, we had an acute occlusion. So we used this approach, and the patient has patency almost 6 months. Another thing that I wanted to see if you are doing peripheral approaches, and I wanted to ask, we sometimes have slow flow after using paclitaxel coated balloons in below the knees lesions. And I wanted to ask you if you have any idea what could be the mechanism.
For what? Sorry, for below the knee, what?
When we use paclitaxel coated balloons below the knee,
Yeah.
we have a slow flow almost
Yeah.
every time.
Yeah. So the mechanism is related to the crystalline formulation that you're using with your DCB for the periphery. And it's associated with a distal embolization, which does not seem to be an issue for coronary. So far, there are no data showing it is an issue. But for the diseased vascular bed in the periphery, if you treat, especially if you treat, how many DCB did you use? It's here. It's five, you said, maybe?
In
Five?
this patient,
Yeah,
I think six. We use
six.
six.
So this is something that we don't recommend, using a six paclitaxel DCB, because the total dosage of paclitaxel around is too high, and especially with these long balloons, you can by far um, uh, exaggerate the limit and overcome the limit that is suggested with such a drug that has a very narrow therapeutic window. Okay, so this is an important point. Another important point is that it's correlated with distal embolization due to the crystalline formulation. So this is why you have a lot of slow flow. You have embolization of the plaque for sure, but also of paclitaxel crystals. So this is why for below the knee data with the newer formulation of DCB, another study that you should cite is the ACOART study done for below the knee. For the first time, a paclitaxel-coated balloon is showing a good result for below the knee. That's a Chinese company. So we have to present it next time, okay, for below the knee,
Okay.
because they have a different formulation. So they are not using these old style first generation paclitaxel coated balloons, which are working well for the coronaries, but are debatable for the below the knee. Okay. And then there is a big room with still lack of important data, but it's a big room for sirolimus for below the knee. So I think that's going to be potentially a game changer. I don't know if Bharat, you have other thoughts about that? Or I don't know if you do any peripheral.
No, I don't. The only sort of I mean, peripheral is access for Impella that we do, but yeah, our vascular interventional radiology do the peripheries here, so it's quite territorial. If you try and do it, then they'll get angry.
Okay, you cannot touch them. Yeah.
Yeah, but they do. I mean, we've assisted them with orbital and things when they first started doing it. Their devices are bigger. I think the burr size is much larger. But yeah, they've started to do orbital. They've done a little bit of IVUS, but like you said, very, very little, less than 5% imaging. Most of it is angiography guided.
Yeah. Okay. Any other comments or questions for Leo? Okay, so we're good. Thanks a lot. This case was actually very interesting and technically challenging, so I think you did a great job. So thank you for sharing it.
Yes, thank you, Dr. Lowe. Very nice lesson. Thank you very much, Prof.
All right, so take care. Thanks a lot, guys.
Thank you. Bye.
Take care, everyone.
Thank you. Bye,
Bye
guys.
bye.